Back in the 90s, we had one drug. It was a parenteral prostacyclin. That's all we had. It was cumbersome. You had to give it by IV. Early 2000, we came up with an ERA, Bosentan, subsequently PD-5 inhibitors. So over the last couple of decades, now we have 3 classes of medications, several medications in each class, so much more to choose from. And we tend to be a bit more aggressive nowadays. This is still considered a fatal disease. So even though patients may seem stable and do okay, we want to get them to a place where they're doing well. So we tend to be, in a nutshell, use drugs up front and add a second or third drug much more commonly nowadays than we used to, because we have them available.
Yeah, I would agree. I think things have moved from sort of monotherapy to dual therapy, and now increasingly to sort of triple therapy, in the similar way that other diseases have developed that way too. I think in the past we used to wait for patients to deteriorate before we added things on. Increasingly we're finding that maybe intervening earlier is better for patients, and they decline. You know, this is a rapidly declining disease, and if we can slow the rate of decline, patients have fewer morbidity events over time and actually have better quality of life living with this deadly disease.
Yeah, so macitentan is an endocrine receptor antagonist. We've got selective and non-selective antagonists. Macitentan is the newest we have. It's again, as I mentioned, approved based on the Seraphin study. We're using it more and more. It's a 10 milligrams once a day, so easy drug to use, and a major medication in the ERA receptor antagonist class. We also have PD-5 inhibitors, sildenafil, tadalafil, and we have the prostanoids. Several prostanoid therapies, including the oral prostacyclin receptor agonist, selexipag, that we discussed earlier. So several classes of drugs, and ERAs, like macitentan, a major classification, and that we're using in virtually all patients nowadays.
Yeah, I mean, a characteristic of this disease is that the arteries that supply the blood from the right side of the heart to the lungs get progressively thickened and tighter. So one of the key mechanisms for all of these drugs is as a vasodilator, to dilate the arteries to allow the blood to get to the lungs where it picks up oxygen. So it's done by 3 different mechanisms, so there are drugs in 3 different categories, but essentially in different ways we're looking to dilate the artery so that we can allow the blood to get to the lungs.
Endothelin is a very potent vasoconstrictor, and we want to open these. I tell patients they have millions of little hair-sized vessels in their lungs, narrow, tiny little vessels, 100 microns, the size of a hair, and they get narrowed and constricted, and we got millions of vessels doing this. The right ventricle can't get blood pumped into the lungs. It's trying, can't do it. It gets enlarged, it gets dilated, and hypofunctional, and fails. So the ERAs or drugs help open up these vessels.